Welcome to the Neuroethics Learning Collaborative panel discussion on brain imaging. Today our two guests are Geoff Aguirre, who gave the earlier lecture on brain imaging, and as you'll remember, Geoff is a professor in the neurology department here and has done much wonderful work over the years in both the methods of brain imaging and also research on the visual system using brain imaging. Seated to his left is Stephen Morse. Stephen will be giving a lecture later in the series on neuro law, but let me tell you about him now. He's a professor at the law school. He is both a licensed clinical psychologist and a lawyer and specializes in mental health law. And he's had the excellent taste and judgment to become very interested in the role of neuroscience in law and neuroethics. He co-directs the MacArthur Law and Neuroscience program and has written extensively on issues of responsibility and neuroscience. So I thought we would start our panel discussion today with an aspect of the role of imaging that hasn't come up yet in the course. And that's the role of imaging in psychiatry, specifically psychiatric diagnosis. As my friends here just heard, I just got in from a trip where in the hotel room I was watching television and I finally saw with my own eyes Daniel Amen and his very popular TV special, Grow the Best Brain or Your Best Brain Ever. I can't remember what the title is. But anyway, he's very well known, you might say notorious among some neuroscientists and clinicians for claiming that he can diagnose a variety of different psychiatric illnesses using brain imaging, specifically a technology called SPECT, which I think Geoff mentioned briefly in the beginning of his lecture. The specific technology isn't important. What is interesting is that he has a whole lot of different tips and advice and methods for not only healing the brain, but actually kind of optimizing it. And some of those are based on the results of brain imaging. Now, you might say, well, what could be more relevant to diagnosing a mental illness, which is, after all, an illness of the brain, than brain imaging? And it makes enormous intuitive sense to think you want to figure out what's wrong with somebody, you want to diagnose their psychiatric problem, scan them. But interestingly, it turns out that in the opinion of most practitioners and scientists, brain imaging does not have much to offer yet for psychiatric diagnosis. And I think this is an important ethical issue, partly because a lot of people are paying out of pocket to have these diagnostic scans, but also because it speaks more generally to the role of brain imaging in society and to the very seductive allure of brain imaging, that sense that, well, gee, if I can see a specific pattern on a scan, that's got to be telling me something. I must have learned something that I didn't know before. So with that as introduction, let me first turn to Stephen, who is a clinical psychologist, and ask him to just tell us a little bit about what goes into psychiatric diagnosis.
Okay. Well, virtually all the criteria for psychiatric diagnoses are behavioral, broadly conceived to mean things like perceptions, thoughts, feelings, and actions. We do not diagnose psychiatric disorders on the basis of brains, nervous systems, or anything else biological. Indeed, in the most recent run-up to the next version of the Diagnostic and Statistical Manual, which is going to be DSM-5, which the American Psychiatric Association hopes to have ready by 2012, it will replace the 1994 version, DSM-4, which was updated just in the text part, not in the criteria in 2000. They were hoping to be able to find biomarkers. The hope was, with the advances of neuroscience and biological sciences generally, that we would find valid neuromarkers for psychiatric diagnoses. That has not turned out to be the case, as Martha alluded to. And if you actually look at the behavioral, and again, broadly conceived behavioral, diagnostic criteria for all the mental disorders, they are sufficiently vague and fuzzy, the way they're defined, that it wouldn't surprise anybody who has any sophistication in neuroscience to know that you're not going to find good, clean brain cuts, as it were, for behavioral conditions that are so fuzzily defined with so many overlapping categories and the like.
So Geoff, I know you've been thinking some about how and why brain imaging is not quite ready to be a diagnostic tool in psychiatry. Do you want to just recall some of your thoughts there?
Well, just to begin with, I think we can echo Stephen's thoughts on this topic, in that certainly there's no reason currently to go to a physician and say, oh, I think I might have depression, please get me an fMRI scan, right? And there's no justification in the literature currently to use these functional imaging methodologies to either try and diagnose psychiatric illness, to try and come up with the right treatment for it, or to prognosticate about how someone's going to do in the future. That being said, it's not an impossibility that these techniques couldn't have something to add. It's just there's a lot of heavy lifting to be done. And probably one of the first things that you encounter when you start thinking seriously about, well, okay, what would it mean if we had a functional neuroimaging of psychiatric illness, is you have to ask yourself, okay, well, what is the gold standard? What is the measure that I'm going to use to be able to say, well, how good did my neuroimaging technique do at diagnosing depression, for example? Well, what you realize is that, well, how we define depression currently is by a behavioral measure. So there's no way that a neuroimaging test could ever do better, in a sense, than as for just doing a raw diagnosis, is somebody depressed or not, than the behavioral measure. In fact, ask yourself this question. Suppose you had somebody in front of you who had taken to their bed for days, have periods of crying, they're not eating, and they're sleeping poorly, all the classic clinical signs of depression. And then you take them and you do a neuroimaging study. It comes out, says that they're normal, they're not depressed. Is that someone who you would not then treat? Is that someone who you would then say, oh, buck up, you must be feeling great, right? I mean, clearly there would be a dissociation there, and you would want to rely upon the behavioral measure, which is how we think about and conceive of these disorders. Now, that being said, if you sort of move up one more step in subtlety and sophistication about this, you might think, well, how about this? Maybe it's the case that you could use neuroimaging to, for example, prognosticate better than behavior could. And that would be an actual empirically verifiable claim that could be made with neuroimaging. That is, I'll scan a group of people right now using PET or SPECT or functional MRI, and I'll make a prediction. I'll say 90 days from now, I'll be able to predict 90 days from now which of these people will still be depressed or won't be, or which of these people will have responded to a pharmacologic therapy or talk therapy or won't. And then you can test it. And if it works, okay, well then you've made an advance over current practice, perhaps. You'd have to show that. But at least you can escape from this sort of otherwise tautological state of not being able to improve upon the very behavioral measure that you're trying to look at.
But let me, okay.
Could I just interrupt with one second?
Sure.
Martha said something earlier that I just want to caution about. She said psychiatric disorders are brain diseases. Now, many people take that for granted, but it's just worth noting that many people do not. If what we mean is there is going to be a biological basis for every kind of behavior, that is of course true. But deciding that something is a brain disease requires a number of assumptions about what counts as a disease behaviorally before you can call it a brain disease. I mean, we have to decide that this behavior is sufficiently abnormal before we're going to be willing to call it a disease. Then it has a biological basis. Does that make it a brain disease as opposed to a biological basis, let's say, for being highly intelligent or something of the sort? So this is a fraught question, and that's all I want to say about it. I don't mean to be arguing it one way or the other, just that it's a fraught question.
Okay.
Right, and just because I can't let that go, because that's such a great thing. You can imagine just because you can find a biological basis for some behavior, which is an undesirable behavior, does not then automatically qualify that thing as a disease or something that's not the person's fault or it somehow is automatically exculpatory. right? So you can imagine that there must be other sorts of measures that we're going to have to bring to bear to decide, oh, well, that's a disease, and that's a bad behavior, and that's a bad habit, other than brain imaging results or neuroscience, simply because necessarily we're going to have to end up finding out that any one of these behaviors or things we look at are going to have a brain basis, because that's kind of where all the action is.
Right.
One last line. I
see the problem is not going to be keeping these guys talking.
This will help you. It's a wonderful line that was suggested to me by a writer for Nature. Actions speak louder than images. Where you see the dissociation that Geoff referred to between behavior on the one hand and the image on the other, unless you've got a question of malingering, which sometimes you will, you always have to believe the behavior, as Geoff said. If this person is depressed clinically, they're depressed. I don't care what their brain looks like. And if someone is out of touch with reality, they're psychotic. I don't care what their brain looks like. And if their brain looks like hell, but they're firmly in touch with reality and are behaving normally, they're not mentally ill, even if their brain looks really broken.
Totally agreed. We're unanimous on that. But let me say that I might be more optimistic about brain imaging than you guys are, or at least than you guys are sounding, in the following way. If you set up the problem of, how useful can brain imaging be diagnostically in terms of, how closely can it match your behavioral diagnosis, then, just as a matter of, syllogistic, logic, right? It's never going to add anything. If, on the other hand, you say, these behavioral diagnoses, they're all we've got. We have to use them. They work pretty well for a lot of things, but we know they're not ultimate truth. And in particular, we know that the diagnostic process that DSM-4 embodies can often lead to two people with plainly different things wrong with them getting the same diagnosis. Okay, it can also be the case that people can have psychiatric features, psychiatric signs and symptoms in common and end up with different diagnoses. And so you have the sense that there is this kind of like more abstract, or at least there's this non-biological level underneath which there is kind of structure in the biological realm which may not map perfectly onto the behavioral. And it may be perfectly valid to say, you know what, in some cases, given a choice between the psychological way of cutting things up and the neurological way of cutting things up, including, sort of distinctive types of brain images, sort of clustering on a brain image level, I think, that brain level is what's telling. And so, again, just to go back to our friend Daniel Amen, his claim is that, there are all these different types of ADHD. The problem the mistake we make is, calling them all ADHD. Really, there's all these different kinds, and he has his little puffy, SPECT images with the holes here versus there. Do you? Yeah.
Well, here's the way I actually agree with what you just said, but let me put it a slightly different way that may be more helpful. My view is what we can be using neuroscience for in this regard is what I would call, now I'm riffing off John Rawls's moral or political reflective equilibrium, reflective scientific equilibrium. We have different behaviors. We like to think we probably have a different biology. So here's what we can do, it seems to me. We can use both the behavioral evidence and the neuroimaging evidence to help refine the concepts of both. It's not going to go in one way, it's going to go in both ways. And if we find that there are different biological substrates, that is a suggestion that maybe we should be slicing the behavioral pie somewhat differently. But then if the behavioral studies don't seem to go along in the same way, well, maybe the neuroscience is somewhat misleading us. But it's going to be, in my view, a reflective equilibrium between the two different levels of explanation. And that's the way I think we're going to make progress both in the biology and in the psychology.
No, I think that's a fantastic concept. And let me just ask you a question, Geoff. But first say, I think the sort of back and forth is exactly the way that we all hope it's going to go, and why we're interested in imaging, certainly as a research tool in psychiatry, if not for diagnosis. The problem, I think, just so that I don't sound like I'm in favor of diagnostic imaging for anything, including ADHD right now. I think the problem is there's a lot of heavy lifting, as you say, to be done to demonstrate that there really are reliably different patterns that have any kind of predictive value in terms of outcome, response to different therapies, whatever.
Right.
And Geoff, can you comment a little on the kinds of things that you need to show?
So in your setup for the question that you initially posed to Stephen, you said, well, maybe it's the case. Maybe we might find that brain imaging would provide a better way of thinking about psychiatric illness, classifying psychiatric illness. So that really then immediately prompts the question, well, okay, well, what's better? Like, what do we mean by better? And that, I would argue, will bring us right back down again to, well, prognosis and treatment and being able to actually be able to make predictions that turn out to be useful. I mean, so for example, if tomorrow I reported an imaging study where I said, I've made a tremendous discovery. It turns out that the functional brain changes that underlie schizophrenia are identical to those of nose picking, right? So it turns out nose picking and schizophrenia have the same functional brain changes. It's the same disease. They should really be classified together. Now, no one's going to take me seriously simply because, nose picking and schizophrenia are such manifestly different sorts of behavioral things to do, right? So it would have to be the case that I would then have to be able to follow that on with, you know what? So not only that, I'm now going to go out and demonstrate that that's true, or cash this out in a way that makes sense by showing that, okay, the same sorts of environmental influences lead to both schizophrenia and nose picking, right? And I can show that these sorts of things in utero exposures, things that happen to kids when they're growing up, they both produce, or the same genetic influences, or the same treatment turns out to be remarkably effective for the two of them. Isn't that counterintuitive? You tape the index finger so you can't put it up there, then that treats both diseases, right? It would have to be something.
Or antipsychotic for nose picking.
Exactly. There would have to be something, right, to end up making that. So, which is why I, for one, am reflexively skeptical of neuroimaging studies that say, look, you know what? We found that it turns out that depressed people and people with in the manic phase of bipolar states have the same sort of functional brain pattern. So therefore, they're the same thing. Well, we just don't know that yet. I mean, that could be any one of a number of different ways you could get that result without those two diseases actually sharing some useful common underlying either influences or subsequent prognosis or treatment. So I think that's what, so at the end of the day, there's a lot of neuroimaging that can be done for basic science research where you want to try and answer the question, well, how does the brain do this? How are neurons organized? And this is fascinating basic neuroscience, which is of the same intellectual category in my mind as sort of astronomy. Like, you want to know how the universe is put together and how the stars are arranged in the sky, right? But the moment you start talking about clinical entities and you want to say, oh, you know what, I'm going to teach you something about depression, or I'm going to make a difference about schizophrenia, well, now we're talking about a clinical activity, and boy, you better have something to show for it, where you can make a prediction or a treatment better. And so that, in the end, I think is what's necessary.
Yeah, I mean, the question that's being raised by the last part of the discussion is how one goes about validating psychiatric diagnosis, showing that this cluster, whatever are its criteria, this cluster is how nature is carved at the joints. And Geoff has suggested some of the ways you do it typically. Do the people with this set of criteria, do they have the same pathophysiology? Do they have the same sort of genetics? Do they have the same sort of brain function? Do they respond to the same sort of treatments? Do they have the same sort of prognosis? And what you'd think is, to the extent that people are clumped in a group, there would be similarities in those sets of criteria, and they would be different from people with other sets of criteria. So if their same drug is working seemingly for two very disparate things, you wonder if they really are different things or not.
And so just so I don't look too reflexively pessimistic, the truth is that brain imaging, despite all the caveats that we've offered here, might be a fantastically efficient shortcut to move your way through centuries of theory and testing and puzzling out the relationship between some very complicated behaviors. It might be the case that if you find, oh wow, remarkably, if you look at resting state correlated activity, you're going to find that the manic phase of bipolar disease looks just like one class of schizophrenic behavior, but not the other one. Well, then that might lead, to then being able to have a testable theory, which would save you what otherwise would have been, many long hours in the clinic trying to match these things together.
Absolutely.
Right.
And I mean, you know, Helen Mayberg's wonderful deep brain stimulation therapy for depression was suggested to her by findings from brain imaging, essentially. So clearly it has many positive roles to play outside of diagnosis.
And it might even be possible, right? It's not impossible at all that there could be things that you would find on a brain imaging study which would be completely unavailable by any other method, such as behavior, right? So it's not impossible that you would be able to take a measure from a brain imaging study, which would then allow you to say, oh, this person should get, you know, pharmacologic treatment, this person should get, you know, talk therapy for their depression, and that would be a better predictor than any other kind of behavioral measure you could take. Because there are examples of that kind of thing in medicine fairly routinely. There's EMG nerve conduction studies, which examine the function of a nerve after it's been damaged. There's no measure of the strength you can make in the hand that will tell you whether or not down the road that nerve is going to grow back and get the strength back in the hand after it's been damaged. But an electrical study of the nerve will tell you that. So there are sort of plenty of examples of cases in which, in medicine, and perhaps now in brain imaging as well, you'd be able to have predictive value that you couldn't get from behavior.
Absolutely.
The beauty of prediction, as Geoff said, is you don't have to be too theoretical about prediction. You just need to get an empirical kind of finding that's good and robust, even if you don't know why it should be so. So, you know, the classic example in psychology was the way the MMPI was developed, right? It was just purely empirically developed measure. There was no real theory behind the MMPI. It just turned out to be the case that people who answered questions in a certain way clustered together, and other people clustered together in a different way, and it turned out to be very useful for all sorts of reasons.
Note that conceptually it's pretty clear what you have to do to be able to validate the use of imaging in this way. Practically it's going to be very expensive.
Very expensive.
So, you know, it may not be tomorrow, and merely scanning a lot of patients does not constitute the right kind of research design. You really need to be scanning people, assigning them randomly to different kinds of treatments, if what you want to predict is treatment outcome, and you know, following up, and that's hasn't been done yet.
Just look at how hard it is to do clinical trials just on behavior, right? So all you want to do is develop a new antidepressant medication, and how many people have to be studied, and how difficult it is to recruit people, and work around placebo effects and all the rest. So, and there's no necessary reason why brain imaging will be any easier to do.
So
plus, it's expensive, and as you all know, many people are not easy to scan. You have to be able to lie still, and you know, there are problems.
Okay. Is there anything that we can diagnose with the help of imaging at this point? Any mental problem? Like I'm thinking.
Well, the American Psychiatric Association thinks no at present.
Okay, but Alzheimer's disease. I mean, there certainly are good tests for. I mean, Medicare, what's the one for old people? Medicare.
Oh, well, you're no longer talking psychiatric disorders, though.
Well, Alzheimer's is maybe on the edge.
So, okay, so more
DSM.
broadly, is there a functional imaging modality? So there's something that's not looking at structure of the brain,
right,
but actual function, either metabolic or in response to task-driven activity, that would allow you to classify someone as having a particular diagnosable illness. That's the general perhaps question to start. Okay, Alzheimer's gets close, though I would argue that even in that case, clinical practice has really moved away from using PET and SPECT and functional imaging scans to try and diagnose Alzheimer's disease, because it really doesn't, it's a complicated topic, but it really doesn't provide much advantage over what you can get just by taking someone's history and identifying that they have a progressive memory impairment. Where it might be helpful in the future is that you might be able to make that determination slightly earlier than you could just behaviorally, and then you can enroll people in clinical trials, and that might help out.
Right.
So
it was Pittsburgh. Right, what is that ligand? PIB.
Pittsburgh, right.
There's a PET ligand that's useful
right,
for that.
For beta amyloid, and so that's an antibody which is directed against a protein which collects as one of the signature pathologic markers of Alzheimer's disease, and so there's been pretty good evidence that that does better. You know, do we call that a functional imaging study? I don't know. I mean, it's probably in the same category as doing a lumbar puncture to collect spinal fluid and look for elevated levels of tau protein. It's the same kind of thing. It's just instead of measuring it in the cup that comes out, you're measuring it by putting an antibody in and looking for its neurofluorescence.
Okay. Okay. Well, I will note for the record that, I mean, I believe, you know, Medicare will reimburse for PET scans under certain circumstances when sort of by behavioral criteria the diagnosis is unclear.
The place where it'll turn up is if you're trying to figure out if someone has Alzheimer's disease or frontotemporal disease, which are two neurodegenerative disorders, and the PET scan or a SPECT scan can help elucidate that. Honestly, and somewhat depressingly, with very little consequence as a result, because for the two diseases, there's not a whole lot you can do for either of them.
Right.
But you know, but let's more broadly. So, are there at least credible claims that you could use brain imaging, either of structure or function, to identify specific psychiatric diagnoses, right? And I know of a little bit of this stuff to do in schizophrenia, and a long-standing search for a structural imaging correlate for schizophrenia. So for many years, the standard textbook statement, at least what they had me memorize when I was in Dr. Kindergarten, was that schizophrenics have slightly larger ventricles, the normal fluid-filled space in the center of the brain, that it's slightly larger in schizophrenics than controls. Well, that may be interesting as a population average finding, but boy, that's not going to help you diagnose any one person with schizophrenia, because there's a lot of things.
Although it was introduced at John Hinckley's trial as evidence that
Yeah,
he was
also
schizophrenic
the width of the cell side.
Interesting, the width of the cell side, which would be highly correlated though with probably with that ventricular measure,
ventricular
just
measure.
overall atrophy.
Brains, yeah.
The poor psychiatrist really got taken apart, though.
At the Hinckley trial?
Yeah,
Very
a fellow
interesting.
named Baer
Baer.
from Harvard. They
Yeah.
just ate him alive.
Well, and probably justifiably so. You know, I think a place where this works, so, you know, the drive to try and use neuroimaging, both structural and functional, as a technique for prognosis and diagnosis and classification is getting a real strong leg up with some recent advances in the field of using machine learning approaches, where instead of sort of saying, well, I'm interested in the thickness of the insula, that's going to predict who has schizophrenia or not, you say, forget it, I don't care where the problem is in the brain. I'm going to take 100 people who, over time, I've followed them and discovered that they have schizophrenia, and 100 people who I've followed and turned out that they don't, and I'm going to throw their brains into a big multi-voxel pattern classification technique, and then just let the computer figure it out. Which points in the brain, doesn't matter in what combination and where they are, lets me classify people as being in one category or another. And using a technique like that, a group actually here at the University of Pennsylvania, in Christos Stavridikos' group, has found that they can do quite well predicting which structural brain scan came from a schizophrenic and which one came from a control. So they're able to train with one group of brain images and then test on another group of brain images that the classifier has never seen. And I don't remember the proportions, but pretty good, like 80–90% accurate in saying, oh, this person is likely schizophrenic, and this person likely received the label of being a normal control. So that kind of thing, I think, is possible. And there's already some evidence that, you know, at least you can find these structural or brain imaging markers to dissociate these groups. And again, we then quickly come back to this problem of, well, how do we do better than the behavior? How do we do better for prognosis or treatment or anything else? But at least it looks like there's some grist for the mill.
Now, here's another preliminary finding of just that sort. One of the people in the MacArthur project has access. He's got a portable scanner, believe it or not, 1.5T, which is in a trailer kind of thing, and he's parked it at a New Mexico maximum security prison, and he's got data on 700 prisoners. Really good scans on 700 prisoners. And one of our colleagues has just done a pattern classifier and is able to predict the Hare Psychopathy Checklist revised score of the 700 prisoners within a point or two.
So that is
based on the scan.
How similar the person is to Hannibal Lecter.
Exactly, right.
So let me just add that, of course, I mean, these are great examples and show that, you know, really within our lifetimes, there's every reason to believe that brain imaging will play a useful role, you know, even in diagnosis. But before it's really useful for diagnosis, it needs to not just tell us, is this person a psychopath or is he not a psychopath? Or is this person a schizophrenic or is he not? But is he a schizophrenic or a psychopath or bipolar or something else, right? That gets a lot more complicated.
Sure, sure. It's pretty easy or relatively easy to distinguish disease from control, but telling depression
what flavor
from,
of disease.
Yeah. Here's the classic example. You probably all saw recently in the newspaper that someone has really got a good alleged neural signature for post-traumatic stress disorder, which is considered a form of anxiety disorder. The problem, of course, is the person has never tried this out on all the other anxiety disorders to see whether it's really specific to PTSD or not. It's precisely the issue Martha just raised.
So let me try to sum up where we've gotten to with this question of imaging in psychiatry. We like imaging in psychiatry for research, for basic research into pathophysiology, what brain systems are involved in creating the symptoms of various different disorders. We are optimistic about, in the near term, perhaps having biomarkers for prognosis, for treatment response. We see some early examples of not full-fledged diagnosis, as in it's this disorder, not that disorder, not differential diagnosis, but certainly very impressive statistical techniques that look at, I guess, mainly structure at this point, or binding of a certain antibody for amyloid protein or whatever, that do a dandy job saying, normal versus this particular pathology, or perhaps distinguishing between Alzheimer's and frontotemporal dementia. Bottom line is, if you or a loved one have some psychiatric problems and they're hard to diagnose, and unfortunately it's often the case that people can't easily be pigeonholed in the DSM-4 categories. Probably getting a scan is really not going to add anything to help you get better treatment.
And it's in precisely those cases where the behavioral evidence is unclear that the imaging helps you least, because the imaging is going to be most specific where you have clear-cut cases. Where the cases are less clear, the images are going to be less clear, unfortunately.
So that about sums up the role of imaging at present in psychiatric diagnosis. But as we've observed over the last few weeks, imaging plays a role in all kinds of non-medical contexts. Marketing, education, the courtroom. Let me just ask each of you, do you have a sort of a favorite example of a use of imaging that you either think is, interesting and promising, or interestingly unpromising? Geoff, you look like you have.
Oh no, I was just going to insert the word unconscionable, which is how I describe most of the uses of neuroimaging that have appeared out in the general lay press.
Here's my favorite example, because it's based in this particular case on good science. As some of you may know, in 2005, the Supreme Court of the United States had to decide whether capital punishment could be constitutionally applied to people who committed capital murder when they were 16 or 17 years old. And as part of Friends of the Court briefs, a number of professional organizations like the AMA and the American Psychiatric and the American Psychological pointed to the diffusion tensor imaging that shows that myelination of cortical neurons is not complete at, let's say, 18, but continues right through until the middle and even the late 20s, and argued, see that, the adolescent brain is not fully mature, therefore it would be unconstitutional to put adolescents to death. Now, with all due respect, this was a non sequitur. The conditions for responsibility in law and in morality are not brain conditions, they are behavioral criteria, rationality criteria. We have known forever that adolescents, on average, are different from adults. We knew that behaviorally, we knew it anecdotally, and we certainly knew it from lots of good behavioral science studies. So what did the diffusion tensor imaging add? Well, it was convergent evidence. I mean, wouldn't we have been surprised if there was no difference on average between the adolescent brain and the adult brain? Of course we would have been surprised, because there is such a persistent and large average difference between the two groups. So in the event, the Supreme Court did not cite this material. It cited just behavioral studies. And to my view, that was the right thing to do, because it would have suggested that brain criteria were doing the work, and they weren't in this particular case. It was the behavioral criteria that were doing the work. And this was a case where the science was good. It wasn't junk science or people overclaiming. The only overclaim was to suggest, because the brain is different, we must treat people differently. That doesn't follow. It's a moral question, who we treat differently and why. And the brain can't answer that question.
So yeah, I think I have an example of where there is an overclaim, and a particularly egregious one at that. So if I really want to grind my teeth at night, I think about this group which has set up shop out in California called NoLiefmri, or NoLiefmri. And their service that they offer is that for a nominal fee, you can come and be scanned, and they will then produce a report which indicates are you being truthful or not truthful about some subject matter which they query you about while you're in the scanner. Now, okay, the science behind which that claim is made and about which they base their generous fee structure is a paper that appeared in NeuroImage a few years back, wherein it was shown that if you placed a cooperative college student in the scanner, that you could discern if they were at a given moment accurately reporting which of a given playing card they had selected in advance, or if they had chosen to be deceptive about which playing card they were going to report that they held. Okay, that was the circumstance. So over an hour-long period of scanning with multiple repetitions of the person saying, yes, I'm really going to say that I have the ace of spades, or no, now I'm going to lie and say that I have the five of clubs, and doing it over and over again, they were able to show, above chance, that they could discern whether the person was telling the truth or lying about which playing card they held. Wow, you could not imagine a greater inferential distance between that ability and that claim and slipping somebody in the scanner and asking them, you know, did you abduct a child in 1972 and dump the body by a riverside, right? I mean, just the degree of stretch that exists between those two things is so enormous. It's so enormous. And so the gall that it takes of groups like these frankly, charlatans to do this kind of thing, I find quite shocking, yet it's becoming increasingly prevalent. And I could go on for hours about how these folks really grind my gears.
And there are lots of things that come up in the newspaper all the time. You know, we can tell the politics of somebody, you know, by scanning. I mean, these things have now become utterly scandalous. I agree with Geoff. But even when the science is good, you always have to ask, is it really relevant to the question at hand? How does it help us answer whatever the question might be, whether it's a marketing question or a legal question or a clinical question or whatever it is? That question of relevance, even where the science is good, is always the crucial question.
Okay. Well, to close, let me ask for examples, if you can think of them, where the imaging actually does add something above and beyond the more conventional sources of information that we have used in various domains.
It's actually much in Geoff's domain, but the example I would give is in personal injury litigation, where there often can be a question of how much injury the person has actually suffered. With imaging, we can do a much better job at diagnosing brain imagery than we previously were able to do. Brain damage.
Injury, I guess. You said imagery, but okay, brain injury.
Yeah.
Yeah.
What did
you say?
Imagery slipped out. But, yeah.
Oh, did I say imagery? Yeah. Oh, brain injury, brain damage, yes. We are better able to do that, and to the extent that this helps us make more rational decisions in deciding how to assign liability and damages, this is a good thing. Now, a really important issue would be whether we can use imaging in the future to try to diagnose whether a person is genuinely in subjective pain and how much pain they're in. Because this is a really important feature of American personal injury lawsuits, and obviously it's so subjectively judged now that this can be a source of enormous injustice. And if we could do this better, that would be a really major innovation for the law.
Absolutely, and there are, as you know,
people are working on this problem right now.
Pretty promising. Yeah.
Yeah.
Geoff, do you have a positive note to end on?
To end on, so where brain imaging has given us information, boy, and outside of a clinical realm would be particularly challenging to find. Yeah. I don't think I have one right now. So outside of a clinical realm, where brain imaging has provided information that would not have been available by some other means. I think that the domains in which brain imaging have provided enormous value is in the area of a sort of basic neuroscientific understanding of the brain and its mechanisms, right? So that has been a remarkable success story over the course of the last couple of decades. And the things that we now know about the way the brain is organized for all sorts of elementary mental operations and emotions is really dramatic. And so it would be a shame if all of that worthy work was tarred with the same brush that's used now for us to kind of slap down some of these applications in sort of social neuroscience or areas where it seems like a bit of a reach. But the truth is, brain imaging, I think, has made some pretty fundamental contributions to our understanding of the organization of the brain. It's going to continue to do so. And I really do think it has a lot of potential as well to actually bear upon these clinical applications and maybe even areas outside of medicine. But boy, there sure is a lot of hard work left to do.
Yeah, many people say that the hardest question in science is consciousness, explaining consciousness. Neurons are not conscious. Neurons don't have a sense of temporality. They're not about something, but acting human beings are. So how does this 2.5 to 3 pound chunk of gray and white jelly produce all this, right? That is a really hard problem. So at a certain point, we might just hit the wall, although I think we have a long way to go before we hit that wall.
Well, and in that context, I mean, how long have people been doing fMRI, which is really the type of functional imaging that has enabled, kind of rapid progress at many, many different sites, maybe 20 years, something like that.
Early 90s.
So yeah, it's early days. I think both the progress on basic science and also the beginnings of sort of practical help in all kinds of real life situations, from the courtroom to, the clinic.
My only caution would be the genetic revolution. Back in the 1990s, as we were discovering the genome, people said, gee, once we solve the genome, we're going to crack disease, and we're going to be able to do this, and we're going to be able to do that. And the answer is very little are we yet able to do. Although, again, I'm optimistic for the future.
All right. Well, thank you very much.